Ventilator Mastery Series, Episode Number 1, ARDS, Why More Oxygen is Not the Solution. Acute respiratory distress syndrome is a form of diffuse inflammatory lung injury, most commonly triggered by sepsis, severe pneumonia, aspiration, trauma, or pancreatitis. The fundamental problem is increased alveolar capillary permeability, which allows protein-rich fluid to flood the alveoli. Surfactant is lost, alveoli collapse, and functional lung volume dramatically decreases. What remains is a small fraction of aerated lung, often described as baby lung, inside an adult chest. This leads to severe shunt physiology where blood passes through non-ventilated alveoli and fails to get oxygenated, causing refractory hypoxemia. At the same time, lung compliance becomes markedly reduced, meaning the lungs are stiff and require higher pressure to deliver even small volumes. Because only a small portion of the lung is available for ventilation, these remaining open alveoli, are highly vulnerable to overdistension and ventilator-induced lung injury. The central principle of ventilating ARDS is lung protection, not aggressive oxygen correction. Simply increasing FiO₂ is not the solution. Improper ventilator settings can worsen the injury. Lung protective ventilation is the cornerstone of management. Tidal volume should be set around 4 to 6 ml per kg of ideal body weight, not actual body weight, because using traditional volumes such as 8 to 10 ml per kg will inflate the limited functional alveoli and cause molar trauma. Blood pressure must be kept below 30 centimeter of water, measured using an inspiratory hold maneuver, as elevated plateau pressure reflects alveolar overdistension. Driving pressures, calculated as plateau pressure minus PEEP, should ideally remain below 15 centimeter of water, as higher driving pressures are strongly associated with increased mortality. PEEP plays a critical role in ARDS management. Moderate to high PEEP helps prevent alveolar collapse, improves oxygenation, and reduces repetitive opening and closing of alveoli at trauma. However, excessive PEEP can impair venous return, reduce cardiac output, and causes hypotension. So it must be individualized based on oxygenation, compliance, and hemodynamics. FiO₂ should be titrated to maintain an SpO2 between 88 to 95%, avoiding prolonged exposure to toxic oxygen levels. Respiratory rate is adjusted to maintain an acceptable pH rather than to normalize carbon dioxide. Permissive hypercapnia is often allowed as long as the pH remains above approximately 7.2, because protecting the lung takes priority over correcting carbon dioxide. In cases where hypoxemia persists and the PF ratio falls below 150, early prone positioning significantly improves ventilation, perfusion matching, enhances alveolar recruitment, and has been shown to reduce mortality. In more severe cases, especially when the PF ratio drops below 80, despite of optimal settings, neuromuscular blockade or referral for ECMO may be considered in appropriate centers. Common mistakes in ARDS management include increasing tidal volume in response to hypoxia, ignoring plateau pressure, failing to calculate ideal body weight, and underutilizing PEEP in several cases, and delaying prone positioning. ARDS does not worsen simply because oxygen levels are low. It deteriorates when stiff, injured lungs are ventilated, as though they are normal. The ventilator must be used as a protective tool, not an aggressive one.